Welcome to Living Well with MS. This podcast comes to you from Overcoming MS, the world's leading multiple sclerosis healthy lifestyle charity, which helps people live a full and healthy life through the Overcoming MS program. We interview a range of experts and people with multiple sclerosis. Please remember, all opinions expressed are their own. Don't forget to subscribe to Living Well with MS on your favorite podcast platform so you never miss an episode. And now, let's meet our guest.
Jonny Acheson, welcome very warmly to the Living with MS podcast, Living Well with MS podcast, in fact. And thank you so much for agreeing to do it. We're having to freelance this and ad hoc a little bit because our normal recording stuff hasn't quite worked out, but hopefully we can have a really interesting, engaging conversation where we explore a little bit about the similarities and the differences in our two various chronic neurological conditions. So welcome and thank you for being here.
Well, thanks very much, Jonny. It's nice to record this with somebody else called Jonny, who's a doctor who also is from Northern Ireland, who is living with a long-term neurological condition. So,
I know. Well, what are the odds of that?
What's that?
What are the odds of that, eh?
I know. I couldn't. Very slim. Very slim.
When I first saw you on Twitter, probably about a year ago, and all the work you were doing, actually in sort of the time critical medications, and through your art, actually, I just thought I've got to reach out to this guy. There's way too many similarities, and I think probably the first thing we should do is get the inevitable 1 degree of separation in Northern Ireland thing out of the way. So they always say, "Oh, where do you come from?" But actually, if anybody's from Northern Ireland will know it's what school did you go to, and then if you do that, you'll know everybody in Northern Ireland. So Jonny, where are you from, and what school did you go to?
So I'm from Banbridge. I went to Banbridge Academy. Yeah.
Amazing. I mean, I know lots of people from Banbridge Academy. I know people from Banbridge and Dromore. I will not go down that line because it'll be very interesting for us and boring for everybody else. But yeah. I'm very familiar with the beautiful part of County Down. Okay, fantastic. Yeah, I'm from Belfast.
Where did you go to school?
I went to Campbell College. So yeah, and often I'll just say it before you do. The cream of Ulster, rich and thick, and all that sort of stuff is. I'll just park that so you don't get that one on me. That's so, right. Jonny, I thought what we might do. Obviously, we've got a fair bit in common, personally and professionally. Maybe you could start by just giving us a bit of an introduction about yourself, about your background, your personal background, and what you do for a living.
Yeah, so I'm Jonny Acheson. I'm actually an A&E consultant working in Leicester. Went to Queen's University in Belfast, graduated in 1999, and then I did various jobs in Northern Ireland, JHO, SHO. Got married to Heather back in 2000, and then with my training, it was very difficult to get a number back in those days in emergency medicine because there was only 1 or 2 came up a year, and as many people did back then, we looked elsewhere. I took a lat job in Leicester for a year because my brother lived in Lincolnshire. He was working in public health at the time, and I didn't want to commit to coming across for 5 years. So was successful with that interview and went back home again to interview again for this 3rd time in Northern Ireland. Unfortunately, wasn't to be. Got my number in Leicester and then did my training. Obviously, kids were born over here. They're now 17 and 13, and we're well settled. But as far as sort of diagnosis, when I was actually diagnosed with Parkinson's disease back in 2006 when I was 41 years of age, and obviously that was a huge shock time when my kids were 10 and 6, and my career was just literally taken off as such, and that was just the biggest curveball I've ever been dealt in my life. And I know you're similar in your situation.
Yeah. I mean, yeah, it's hard to know. There's so much to unpack in that, but I suppose the first thing, just to give context to our listeners, would be that there's a whole generation of doctors in the UK in sort of the early to mid 2000s who were, I don't want to use the word victim, but certainly had to survive under the new MTAS system, which basically meant that actual training jobs with career progression could be very, very difficult to find. And there's a thousands of doctors that have left the UK and never came back and went to Australia, New Zealand and elsewhere, and others like yourself, Jonny, who maybe didn't plan to have to move around the UK to get their training number, but did. So it's great to hear that you've flourished outside of Northern Ireland. I think a lot of people in Northern Ireland forget that there's a world outside of it, and that's another topic for another day. But yeah, so just to with regards to your Parkinson's diagnosis, is that something that came completely out of the blue? Is it something that had been sort of there in the background for months or years beforehand, or what was it that sort of initially brought you to that first consultation?
I mean, to be honest, it was out of the blue, but I knew something was wrong. So it was about 6 months before my in-laws had come over to visit us in Leicester, and they hadn't seen me for about 4 or 5 months, and they sort of said to my wife, something wrong with him. He's not really himself. He's a bit withdrawn. They couldn't really put their finger on it, and they didn't really say anything to me. But it was really after Christmas in 2016. I noticed that I was getting very tired, so I would fall asleep when I came home from work in the evenings before my kids were in bed. I would fall asleep. Sometimes I literally put my head down on the table like this and work just to rest. I remember vividly, going to my kids' swimming galas where there's hundreds of screaming children, and I would just lie sleeping on a Saturday night. And even in Leicester City Football Club, where we go and watch Leicester City, the year they won the Premier League, 32,000 people singing Jamie Vardy's Having a Party, and I'm sort of sitting like this, fast asleep. So fatigue was there. I also noticed that when I was walking, especially when I was tired, I would scuff my foot and I would go forward as if it hit the curb, and then I'd look around and it was flat. But that didn't bother me so much. And then I was typing in the Leicester Medical School one day because I'm in charge of organising finals, and I noticed the slightest flicker in my left hand, one of my fingers. And I thought, what's this? But the big symptom that got me down to the GP was my mate came into my house one night, Jules, and he said, "Oh, I've just been to a Bollywood dancing class with my daughter." So obviously Leicester's a very ethnic city, a lot of culture. So they'd gone to do some Bollywood dancing. So he said, "Let's all stand up and do the sort of change the light bulb dance, like this." And I realized at that moment that I couldn't rotate my left wrist very quickly. And that was really interesting because I'm right-handed, so I don't use my left wrist to do anything, change the light bulb, screwdriver, etc. So I realized that I didn't know at the time that that was bradykinesia, even though I'd been to medical school for 5 years. I didn't actually recognize that I had bradykinesia. I just knew that my wrist didn't rotate quickly enough, no matter what my brain was telling my hand to do. So went down to my GP quite quickly. She was excellent. She took about 45 minutes. She referred me to the neurologist the next day, and then he took the history exam on me. He got me to walk across the clinic floor. So for all medics listen to this, I assess people's gait all the time. Always wanted to know what it felt like yourself, to actually somebody assess your gait. And I try not to scuff my foot, so I was walking across the clinic, concentrating really hard. I sat down and he said, "You're not swinging your left arm very much." So, and I hadn't noticed, my wife hadn't noticed, nobody had noticed, but why would you notice? So that's basically how I got into the neurologist's clinic.
So it's interesting that journey, once you sort of realized that you needed help and you went to see your GP, it sounds like it was quite quick. So GP to neuro office didn't take very long, and there's similarities there for me. And I'm wondering then, when you were told, "Listen, Jonny, I think you probably have Parkinson's," was that done in a way that you would either want for your patients or your family members? Was it done any differently because of the fact that you're a doctor? What are your thoughts around that one, Jonny?
Well, I think it's very difficult, isn't it? I think it's difficult for any doctor who is treating another professional. So I think that puts them potentially in a different situation, and maybe they do things differently to somebody who's not medically trained. I mean, the neurologist, it was interesting. He after he'd examined me and he knew what the diagnosis was, he leaned across to my wife or to us and he said, Johnny, you need a DAT scan. Now, I've been to medical school at Queen's, great university, great teaching, but I don't ever remember anybody mentioning what a DAT scan was. So I didn't know what that was. I don't know if obviously if you'd heard about a DAT scan in your training.
No, I hadn't.
I didn't know. But my wife, she was an ST4 in psychiatry at the time. And she obviously ordered DAT scans in her clinics to determine whether somebody had Lewy body dementia or not. And she then knew what the diagnosis was, sitting 3 feet beside me. And she leaned across the neurologist and said, he doesn't know what that is. So he sort of reeled back slightly and then said, Johnny, I'm really sorry to tell you, but you've got idiopathic Parkinson's disease. And to be honest, it was literally like somebody pressed the pause button at that stage, because I was totally blindsided. I did not think, I didn't even think that that was possible. It wasn't even on my list. I thought I had multiple sclerosis. I thought I had motor neuron disease. I thought I had a brain tumor. So for him to say those words, it was really quite, it was life-changing news. But I think he was quite sensible, my neurologist. So he said certain things like, I think you need to take some time off work to get your head around this. So he said, take 4 weeks off, which was,
Physician heal thyself, eh?
Yeah. Well, I think he was wise in doing that, because it was so blindsided. I needed time to sort of try to get my head around it. Now, you don't get your head around it in 4 weeks, but at least you start to educate yourself about it, and some things start to make sense. But I think he said things like, this is a progressive neurological condition. It will progress slowly. He said, there is no cure, but there are medications that we can prescribe that will mask the symptoms, but will help the movement. He talked about exercise and the importance of exercise, the importance of high intensity exercise. He talked about diet. He talked about reducing stress. And I think it's really important how that news is given, because that has a very big impact into how the patient perceives the condition and what the outlook might be. And I think neurologists have to, although it's life-changing and you're on a different path now, I do think there needs to be a degree of hope given to patients, and also that they, in a sense, are in control of their disease, themselves. They need to really learn that they can do things in life that will help them. It's not going to stop them having the Parkinson's or multiple sclerosis, but there are certain things that can be done that may help people to live better every day.
I think I couldn't agree more, John. I think that's just such an important message, and it's wonderful to hear another UK-based doctor living with a chronic neurological condition saying, just you need to hear this message. You need to listen to us, to say, I'm sort of thinking as you were talking there's an amazing book by a neurologist called Jules Montague called The Imaginary Patient, about the people behind these diagnoses. People think, oh, that person in bed 4 has Parkinson's, the one in bed 3 is MND. And we often forget the person in the chair. And as you were saying to me there about, how your consultant, and actually sounds in a quite empathetic and really nice way, they were obviously so worried about insulting your medical intelligence, that they sort of reverse sugarcoated it, if that makes sense. That sort of your warning shot. We always talk about warning shots in medicine. We're going to give bad news. Your warning shot was something you were never going to understand because you're not a neurologist. But he also didn't want to. Yeah, it's fascinating. And I can really, this isn't about my story, but I can really, that really connects with me and mine, sitting in the neurologist's office being told there's 2 more lesions in that scan. As if we're talking about a third person, and it's not a third person. It's me. It's a guy who's about to get married, and his fiance sitting there with him, and he's got his whole life ahead of him. And like you, that is a punch right in the gut, which we reel from. And the wonderful thing there is that you were told to take some time off. I think because as doctors on treadmills and with targets to meet and hoops to jump, we're terrible at that. So it's wonderful. Did you take the 4 weeks off?
I did, yeah, I did. I took the 4 weeks off. I never had that
So
amount of time off before, since I graduated. And what I did was I found there was a cyclist in America called Davis Finney. So Davis Finney was an Olympic cyclist, and he was in the Tour de France, and he was diagnosed with Parkinson's at 41, same age as me. So that was the only similarity really between us, our age, and the fact that we both had Parkinson's. I cycle a bit, but I'm not obviously at an Olympic or Tour de France
you're not
level
an elite cyclist.
in any sense. But he produced a book called Living Every Victory Counts, and it was all around, it was a really fantastic resource. It was 300 pages, it was quite long, but I just read that from cover to cover, and a lot of things started to make sense. Symptoms that I had that I didn't realize were due to Parkinson's. So I lost my smell. My wife would come down and go, "Can you not smell the toast burning? Can you not see that I've left the gas on once?" It's like, well, I can't smell. And when I was running, sort of in the mornings, I would get pain in my right knee, and I realized I was overcompensating because I wasn't walking properly, I wasn't running properly. I was putting more pressure on my right knee. So that was interesting. And then all the sort of motor and non-motor symptoms. So the invisible symptoms that you don't see, the anxiety, the apathy, the problems sleeping, all that stuff that is very difficult for people to understand because they don't see it. So the 4 weeks really helped me. I think it taught me two things. One, this disease wasn't going to kill me. Well, not directly anyway. And secondly, that high intensity exercise of 2.5 hours a week may slow progression, but it'll certainly help you feel better and reduce your symptoms down. So it was a very wise thing to say, I think.
And it sounds like a bit like me, maybe another similarity. You went on a quest for knowledge and for answers, and it's amazing to hear that you found it. And for me, it was very much the same. It was George Jelinek work in overcoming MS. He was an emergency. In fact, he's more like you than me. He was diagnosed at 41. He was an emergency medicine physician, but at a time when there was very little positivity about MS, he'd put together all these relatively simple things that I could do, and that was life-changing. It was the light in the darkness, that little granule of hope that you could grab onto and hopefully tend and grow. And yeah, it's funny to hear that from your side as well.
He wasn't an elite
just
by any chance, no?
No, he wasn't an elite cyclist either. No, he wasn't, and neither am I, by the way. Although I do like it. Jonny, just for the benefit of our listeners, I think it's probably worth, maybe if it's okay, just taking 1 minute and explaining what Parkinson's disease is. We're all very clued up in the world of MS, but we forget that there are many other neurological conditions around, one of which is Parkinson's, and that's also very common. So rather than me hashing out what I think it is, perhaps you could tell us.
Yeah, so Parkinson's, I mean, I knew sort of from medical school what it potentially looked like, but so Parkinson's is a progressive neurological condition for which there's no cure. It's caused by a lack of dopamine in the brain because the brain cells within the substantia nigra that produce it have died, and by the time you're diagnosed, they say potentially up to 70% of your neurons have died in your substantia nigra, and that's when your motor symptoms start to present. So there's not a lot of wriggle room. Most commonly, the only symptom that everybody with Parkinson's has is bradykinesia. So everybody's got bradykinesia. Interestingly, 20% of people with Parkinson's don't have a tremor. And that's important for sort of, primary care doctors to realize, because I think the people that present without a tremor maybe take longer to get diagnosed. And then obviously you've got rigidity as well, and stiffness. And then obviously there's a whole range of non-motor symptoms. But the thing about Parkinson's, I'm not sure if this is the same with multiple sclerosis, but there's over 40 symptoms. Everybody is different. So there's a phrase that says we're all the same but different, and we're all labeled as the Parkinson's disease, but there are subtypes, and I think what will happen in the future is, as the research comes on, you'll have type 1, type 2, type 3 potentially it will be Parkinson's diseases. And
Yes.
I think as the research goes on, that will come out in the mix.
That's fascinating. That is exactly the same as multiple sclerosis. Actually, there's a huge catalogue of symptoms. No two people with it will ever be the same. There are hallmarks that everybody thinks of people with MS, but actually for lots of people that isn't their big problem. A lot of people will talk about gait disturbance in MS as well, but for a lot of us, our symptoms may be completely invisible. I suppose maybe the one difference is, and maybe I'm wrong in this, most people with MS are diagnosed between around the ages of 20 and 40. It's maybe slightly later, Jonny, in Parkinson's disease normally. Is that right?
Yeah, that's right. I mean,
Um,
I thought that's why I thought of potentially had multiple sclerosis, because it was only 41, and I know it's more
yeah.
common in women, whereas Parkinson's is more common in men. But yeah, Parkinson's, usually anybody diagnosed under the age of 50 is known as early onset Parkinson's. The vast majority of people with Parkinson's are diagnosed, older than that. So, as your age increases, the incidence increases as well. So.
And the mainstay of Parkinson's disease therapies, if I understand this correctly, it's not that it's really modifying the disease course, it's treating the symptoms, generally the motor symptoms caused by the condition. So what does that look like for the average person? Is that everybody with Parkinson's ends up taking levodopa, or how does it work?
So when I was first diagnosed, I was just started on razazoline for 18 months, which is an MAOIB inhibitor. Because it wasn't, my symptoms wasn't affecting sort of mobility as such, or daily activities. But there was one day I was walking up the corridor, and the nurse said to me, why are you limping? Why are you dragging your foot? And I was like, right, okay, well, obviously this is a bit obvious now. So I started on the levodopa about 18 months after I was diagnosed. So levodopa, you're right. There's no disease modifying drug that will slow the condition down. The medications just mask the symptoms. So levodopa was introduced in 1961, and it is probably the most widely used drug. The difficulty with Parkinson's is, as the disease progresses, your medication is not as effective. So, the drugs I was taking at the start, which would last 6 hours, now that dose only lasts 3. So within 7 years, we've gone from 6 hours to 3 hours, and that brings in the concept of wearing off your medication. So sort of about half an hour before I'm due my next dose, I'll wear off. So I can wear off motor and I can wear off non-motor. So my arm could be just hanging down by my side, not really moving when I'm walking. I feel as if my left leg's like a ton weight. It feels like lead. And then non-motor wise, my brain slows down. I get a bit sort of slower decision making. I can get quite anxious. I think my brain tries to compensate by that, but I actually start to talk more quickly. It's a weird concept. Now, obviously, being from Northern Ireland, whenever you speak to somebody from Northern Ireland, you naturally speak more quickly, because whenever you're in England, and if you try to speak at this speed, nobody understands what you're saying. So apologies on the podcast. I'll try and slow it down. But yeah, was that?
At least we'll understand each other.
Exactly.
That's important.
That's it. So yeah. So it's I think the thing about medication is trying to find a balance. Obviously, side effects, are important. Dopamine agonists are effective drugs. They basically stimulate the neurons that you've got to produce more dopamine. The difficulty with that is you will get dopamine in areas of the brain where you've got enough. So it can cause impulse control problems. So people might eat a lot, people might shop a lot. Gambling, you need to be careful with that. Hypersexuality, it's important that you look out for those things. And neurologists are very good at counseling people with that, and their care partners as well. So it's really just trying to find the balance of what works for you as the individual.
And I'm interested to say that your neurologist right at the start said to you, you know, lifestyle potentially is an important part of this. And I know for you, exercise has become a really important part of how you manage your Parkinson's. But my understanding is actually the evidence in Parkinson's and the role of exercise is really strong and getting stronger all the time. In fact, I saw a news article just last night about a guy, Scott, from Northern Ireland with Parkinson's, who is using exercise and really helping to manage his condition. Can you maybe tell us a little bit about that side of things?
Yeah, so they think that high intensity exercise, 2.5 hours a week, may slow progression of the disease. So it's like anything in medicine, you know, until you get the evidence, you can't say for certain. But you know, I'm pretty convinced. I mean, I think if I hadn't been exercising, I've tried to exercise 2.5 hours a week since I've been diagnosed over the past 7 years, and I've never really gone over 2.5 hours. I usually do about, you know, half an hour, maybe 5 days a week, or I might do an hour one day and then split it up. But you know, I feel so much better having on the days that I do that. You know, there's been a study from Holland that looked. I think they did MRIs on some patients, and then with Parkinson's, and then they put them on an exercise bike, I think for 6 months, and then they did the repeat MRI scans, and I think it potentially showed that there was neuroplasticity happening while people were exercising. I mean, the thing that convinced me was, again, in the Davis Finney Foundation, there's a story about a neurologist who went on holiday with his friend who had Parkinson's, and it was a cycling holiday. And obviously the person with Parkinson's, they decided to get on a tandem bike. So the neurologist was at the front, the person with Parkinson's was on the back. And obviously the neurologist set the RPMs. And after about 5 days of the cycling holiday, with the person with Parkinson's going at a higher rate, they found that their handwriting was much better. And that just struck me as, you know, like quite an amazing study. You know, you're never going to be able to repeat that. And just because the evidence isn't there doesn't necessarily mean that it's not. It doesn't help. And that program on BBC Newsline last night, you know, is an example of that. You know, Scott Hanley, you know, he was a guy who realized exercise could help. He got training, he lost some weight, and he's basically managed to take a bit of control back to managing this condition. And you know, it's very important. I think the difficulty is that, you know, the general population have difficulty exercising, have difficulty motivating themselves to exercise.
Yes.
I think if you're living with a long-term neurological condition, it's so important, but it's trying to keep the motivation that's really quite the challenge. And I think it's about finding something that you enjoy doing. It's finding something that you'll stick at. It's something that, you know, that it's easily accessible. The difficulty with Parkinson's is the vast majority of people, you know, a lot of people are diagnosed in their 70s, whereas with multiple sclerosis, you've got a much younger population, and you guys are probably more motivated potentially to exercise, or potentially find it easier to exercise than people who are diagnosed with Parkinson's at an older age. But there are exercises that can be done.
But you know, 2.5 hours a week is essentially the UK government. Yeah, but I mean, what you're saying, 2.5 hours a week is actually the guidance in the general population anyway. That's nothing above and beyond. That's what we should all be aiming for. And I suppose motivation is absolutely right. I really struggle with that myself. And there's this sort of just turn up is attitude now, where, you know, I'll try and do a lot of sort of body weight exercise and things that I can do at home easily, just stick on the shorts and the t-shirt and go for it. And actually, as you say, every time you do it, no matter how rubbish you feel before you start, if your leg and your portfolio are absolutely killing you that day, the one thing you can guarantee is that you will feel better at the end of it, and probably the day after. So yeah, I just couldn't agree more. And what you're touching on, and with regards to sort of self-activation and that sense of autonomy, control, mastery, I just think it doesn't matter what your condition is, that is just absolutely vital to living well with it. And it sounds to me, Johnny, that's what you're doing. How has work changed for you, if you're asking, since your diagnosis? Have your colleagues been supportive? Have you changed how you're obviously your frontline NHS worker now, you're emergency medicine, we all know in the UK, is getting absolutely hammered. How has that been?
So my trusts, I have to say, have been very, very supportive. So for example, when I was first diagnosed, I was finding it really difficult to multitask. It's one of the non-motor symptoms. It was difficulty, making rapid decisions, and making quick decisions and a lot of decisions in the shift. And I was finding it was knackering me. So they took me off the on-call rota quite quickly. And I was basically put on a Monday to Friday, fixed pattern 8 to 6. Still work one weekend and 4 on a Saturday morning. And that really helped because it gave me organization, it gave me planning. I knew what I was doing. But about 3 years after I was diagnosed, I took another 3 months off work because it was just too much. I was still working in the main department. And at that stage, they decided that I would move to the observation unit, which is the EDU, Emergency Decisions Unit. So people are admitted in there who have been seen, but they need a period of observation. So we've got various pathways. So we'll get anaphylaxis patients and head injury patients. We get a lot of alcohol, a lot of mental health. We'll get sort of waiting results pathways. We'll get abdominal pains that we're not sure what's what. We'll get renal colics, paracetamol overdoses who need NAC treatment, etc., etc. So in a sense, all that training for 20 odd years suddenly was confined to this really, really niche part of emergency medicine. And I sort of felt slightly shortchanged in the sense that, I wasn't able to use my resuscitation skills, but I'm still able to use my training, because there's the odd time you pick things up that somebody's missed. So, last week there was somebody who was sent around on a renal colic pathway, but the pain wasn't in their loin, it was actually in their lower chest, and they had a pulmonary embolism. There was somebody a few months ago that was sent around with acute urinary retention, and actually on the acute urinary retention pathway, but they ended up having an abscess, an epidural abscess. So it's things like that. You can still use your skills. And I think the important thing to say is, if you get diagnosed with a chronic neurological condition or any condition, you don't need to make a decision about work immediately. I think a lot of people worry about the future and what will happen. And I did exactly the same. But, where I am 7 years down the line, I think those choices were right. And I think the trust have helped me adapt, with good, reasonable adjustments. And I think I'm working as hard as I ever have. I'm as busy as I ever have been, but I just need to pace myself and not use up all that dopamine, in one go over the course of the day.
And this is maybe a silly question to ask. Do you think that Parkinson's, and being, someone who's now living with Parkinson's, has that changed the way you are a doctor in any way in particular? I don't mean in terms of, where you're working, etc., but is it given you anything? Is it taken anything away? Has it changed how you manage certain things or talk to patients? Or
do you know
what I mean?
Yeah, I think I think the alcohol, people who get admitted with alcohol are, I do spend a lot of time with them, because people just want you to listen. Yeah. And I think it's really important. I think whenever you get diagnosed with a condition, so Parkinson's, I'm really keen for everybody to know what Parkinson's is and what it's about. But I always say, but I'm only doing that because I've been diagnosed with a condition. And you can't expect people to know about Parkinson's, multiple sclerosis, motor neuron disease, the whole range of conditions. And I think it's really important it's really important to educate your family. It's important to educate your friends, and it's important to educate your work colleagues about the condition that you're living with, because that really helps in those environments. So I would definitely say that if I do get somebody with Parkinson's in on the ward, I will always sort of whisper in their ear when I'm listening to their chest. I'll sort of say, I understand how this is affecting you, because I'm living with it as well. And they sort of reel back a bit and go, well, you're so young. But I think that's important. And that's
living, Jonny, as well.
No, I don't.
There'll be
I don't think that's necessarily the case, because I was in the post office the other week with my wife, and my wife, obviously, I'm 48 this year, she's 47, but she looks a lot younger than I do. I don't know, it must be the moisturizer she uses, or her genes. But I was in the post office, and the woman behind the counter looked at my wife and then looked at me and went, "Are you two together?" And I was like, going, "Well, yes." We've been married like 23 years, and I wanted to ask her why she said that, but I didn't never had the I never had the
That's the. And a senior colleague used to say about my wife Jenny that I was punching above my weight every time he saw me, and he still does. Anytime he sees me, "You're punching above your weight, son." I think it's a compliment. I think it's.
I think he would probably say the same if he saw us. But yeah, I would take that as a compliment as well.
That idea of disclosure actually is a really interesting one. I don't always. I see lots of people with MS, obviously working in sort of obstetrics and gynae. You'll see lots of people, and I sometimes tell them if I feel it's appropriate, but I sometimes choose not to. And in those I don't tell, I always feel a slight guilt, not because I want to tell them about me, but because I feel this duty to sort of, maybe because often the management can be sort of a bit bare bones, and they're not aware of things like vitamin D or exercise or the role that lifestyle plays. And I feel almost this duty that I have to tell them, but it can be very difficult because you're obviously giving a bit of yourself, and you're really taught as a doctor not to do that, and how it might be a bit inappropriate at times. But yeah, that's I like that idea that as you listen to their chest, you just whisper into their ear and say, "I've got it too." I'm not sure how I can do that, but I'm certainly going to think about it.
I mean, I think.
So but sorry, go on ahead.
I was going to say, I do feel as if I have a duty. You're talking about duty there, and I think that's really important, because I feel as if I have a duty to them getting their Parkinson's medications in hospital when they need them, because I think it's a travesty that Parkinson's UK did a study in 2019 that showed that in England and Wales only 53% of people in hospital with Parkinson's got their medications on time. That's why we launched a national campaign back in World Parkinson's Day last year for people in hospital with Parkinson's getting their time critical medication on time. And I think that's the big driver. That's the big driver for us at the minute, to try to get that addressed. But we've made some progress. We're making more progress, and it's going to take, like anything in medicine, it's going to take a long time to sort of get it on the agenda, get attitudes changed, and get care improved. But it just has to happen.
And it needs people doing it on the cool face, Johnny. So you've changed the way you work a bit like me. You dedicate one day a week to working for Parkinson's causes, isn't that right? You sort of work in engagement and advocacy now.
Yeah, so I do one day a week with the Parkinson's Access Network. So Johnny, we've talked about obviously lifestyle changes within Parkinson's, exercise, diet, reducing stress. And what struck me whenever I was reading about multiple sclerosis over the past week is how similar the lifestyle recommendations and changes are for both conditions.
Yeah, I mean, absolutely. I suppose a little bit like in Parkinson's, there's never going to be a gold standard diet or lifestyle approach, and people will argue about the semantics of various aspects. But I think there's absolutely no doubt now, and I'm glad to hear that increasingly more and more health professionals are actually acknowledging this, that diet quality, first of all, if you're purely talking about diet quality is absolutely vital to somebody living with multiple sclerosis. And I imagine in Parkinson's disease, there's got to be crossover there too. And if I could advocate for patients in the way that you do, Johnny, mine would be that I would desperately want every single person diagnosed with multiple sclerosis from now on to be told about the role of lifestyle in modifying their disease trajectory, and how that they can, through relatively simple changes in their lifestyle that don't cost the earth, and that once you get used to them are not actually prohibitive in any way. In fact, I eat a whole food plant-based lifestyle now with additional seafood, and I've never eaten more interesting, tasty food in my life, and I wouldn't change it for the world. It's daunting at the start, but actually it's remarkably, wonderfully empowering, and without a doubt has made a difference to my disease trajectory already. And I think that is something that we really need to get better at, and I think that's, as doctors, is sitting in that space where we're happy enough to say we don't have a randomized control trial on this, but actually that doesn't matter because you can't do RCTs on fake steak, for example. But the evidence base is increasingly coming together and showing a very clear picture that what you put into your mouth, how you exercise, how you manage your stress, has a massive impact on your brain health and your general health.
No, I totally agree with that. I mean, I have to say, I'm probably better at doing my exercise than I am watching my diet. It is an area that I really need to focus on a bit more. I mean, we try to sort of stick to a Mediterranean diet and sort of fish and a lot of sort of lentils and that sort of thing. But still like my meat. You know what I mean? And protein is a big problem for people with Parkinson's because if you have a big protein load, it'll affect the way your medication is absorbed, and that can make you feel a lot worse. So yeah, I'll be looking on the Overcoming MS website just to get a few more tips about that, because I was looking at the website earlier. There's an awful lot of crossover between the two conditions. It's interesting. I was reading it and it said, they're not sure what causes it, but a combination of lifestyle, environment, and genetics. It's exactly the same as Parkinson's.
Absolutely. So. I'm really struck by the fact that MS, certainly it didn't really exist that we know of 160 odd years ago. Yet we now have 3 million people around the world affected, 130,000 in the UK. To me, it's an absolute no-brainer that something we're doing in our lifestyle or something in our environment has precipitated that change, because our genes don't change that fast. So it can't be genetics that accounts for it all. And to completely ignore that side of the coin really is a disservice to you personally. Why would you not do all that you can to live as well as you can with these conditions?
Absolutely.
That's obviously easier said than done.
Well, it is.
I think it's just vitally.
That's the challenge.
Yeah. Jonny, we've taken up lots of your time, but I think we haven't covered something that is very important, and it's what you do outside of medicine. So I know you're a big fan of football and Leicester City, and tell us, you're involved in a Parkinson's football tournament over the summer, I think. Is that right?
Yeah, so we actually have been a couple of times. Every year in Copenhagen, there's a tournament called the Ray Kennedy Cup. So Ray Kennedy obviously played for Liverpool and Arsenal, and he was diagnosed with Parkinson's, in his 30s. So it's really in memory of him. And it was set up by a physio from Copenhagen. But we went over in 2019 as part of the UK young onset Parkinson's football team, which was set up by a guy called Charlie Appleyard in who lives in London, and he's also set up a charity, a CIC company called Sport Parkinson. So it's really good what they've done. But we went in 2019. There was 10 of us. We never played together before the weekend we arrived at the all together in Copenhagen.
Nice. Proper pros.
It was brilliant. So we basically did in England. We won the group, and then we got knocked out in the semi-finals, but it wasn't on penalties. So that was a great experience. And we actually went back this year in 2020, last year in 2022, and we didn't get out of the group that time. But it was a great experience. There's a national sort of walking football tournament in St George's Park in the head of the FA, which happened last year for the first time. It's happening again this year on the first weekend in March, and that's just encouraging people with Parkinson's to play walking football. It really has. It's a great way to get exercise. There's real team approach. It's getting people, and it's social. It's very social, and that's very important with people with Parkinson's, because they tend to sort of draw in themselves, not look outwards. And sometimes it can be very isolating. So the work that they're doing is absolutely fantastic.
So what you're saying actually is that you're an international athlete now.
Well,
fair play. No, fair play.
The only international athlete with Parkinson's is a guy called Patrick Crossan, who's from Belfast, who actually is got his Paralympic classification. So he's the athlete amongst us, and his attitude to exercise has been absolutely phenomenal. And I wish him every success for all the competitions he's going to be entering in the next few years.
Here, absolutely. There's the one last lifestyle thing I want to touch on very briefly is I read a tweet that you wrote on the 18th of January, and it really struck me, which said that I'm learning to always trust my gut instinct. If I make a decision and it causes my sleep to be interrupted, increases my anxiety, and hence my overall Parkinson's symptoms, I've realized that the decision needs to be addressed and reviewed to enable it to be reversed quickly. And I thought that absolutely chimes with me and how I feel about things like that, and what I'm learning about how I need to manage my MS. So perhaps you could very briefly just touch on the sort of the role of stress and how that does affect you.
So this wasn't I was a bit concerned when I tweeted that out, but this wasn't a medical situation, wasn't a clinical situation. Quite confident in those decisions, but this was around art. So basically what happened, I basically started to draw whenever, about 2 years after I was diagnosed. Always drew as a child, but hadn't drawn a lot since then. And basically I set up an art website that initially was set up to educate about Parkinson's. So I drew a series of drawings I called the Parkinson's Portrayed. So it was 32 sketches. Basically I took the word of the symptom, tried to draw a cartoon around it with a strap line to try to get people to understand what it felt like to have the condition. But so it was drawn a lot about Parkinson's. It was drawn a lot about emergency medicine as well. I did a charity calendar for the college one year for a couple of years. But I realized that drawing about Parkinson's that I live with and drawn about emergency medicine that I work in wasn't actually that healthy. So I basically started to draw the most favorite thing I draw now are people's pets. So I actually draw the most popular thing I draw are people's dogs, and I basically draw them. It's based on a silhouette, and through the letters of their names. I've got one here. I'll just show you. So let's see. This is Otis and Arnold. Okay, Otis is a cockapoo and Arnold is a pug, and that's proved quite popular, and I really enjoy doing those. But I got an email from British Vogue there a couple of weeks ago, and they said we'd like to feature your art in one of our magazines in the March edition. So I sort of thought about it for a while, and you had to pay for it, and I thought, yeah, I think I'll do that. And then I started to feel a bit uncomfortable with that decision. And the reason was because I'm a one-man band, one-man show, I was started to worry about getting loads of orders that I wouldn't be able to fulfill. And that sort of got me stressed. And then I thought, well, I'm going to have to draw about 30 pictures to basically even, cover the cost of this. And is that the right decision? And, what happened was for 24 hours, I didn't sleep. I woke up the next morning, my Parkinson's symptoms were worse. I was stumbling. I was I couldn't think straight. I was just stressed. I was feeling real stress, and I thought to myself, you need to sort this out. You need to work out what's causing the stress. So it was that decision to say I was going to go with it, and I basically emailed them back at the end of the following day and said, I'm not ready to do this. Contact me again in 6 months. And I'll see. And I think that's why I sent the tweet out. So it was the recognition that the decisions that you make, if they're going to stress you, then you need to take action, because once you address them and the stress reduces, then you're gonna feel better, and you're going to live better with your condition. So that's really what that was about. But it was quite scary as to how much of an impact it had and how symptomatic it was for those sort of 24 or 48 hours. And I think just brought home the importance of reducing stress and keeping things on an even keel. I always say Parkinson's is a fine balance. I also say it's like being a weeble, the weebles in the bath used to have, and it's really like that, because you're steady. You're not going to fall over, but you can sort of keel to one side, and that sort of care circle that's around you is really important at just sort of holding you back up and making sure you don't implode. So yeah, that was an interesting experience.
Well, as one of your customers and proudly displaying Ross the cat on our wall, I can certainly attest to the fact that you have pretty significant God-given talent for that one, Jonny. So thank you for all of that work as well, and for delivering it on time for my wife's birthday, which was greatly appreciated.
No problem.
But that sounds like a fantastic way to manage your stress. I imagine they always talk about the flow state of when you're doing something that you really love and that you're very good at, how you just take on this wonderful sort of presence and so focused on the moment. And that's something that I just think that all of us living with these conditions really need to find, and it can just be so beneficial.
Well, I think you're right.
Thank you.
I think you're right. I was just going to say it really is, because you can get a bit distracted with Parkinson's, and I think what's good about finding a hobby or an interest is that it does focus the mind, and it does settle you down, and I find it helps with motor symptoms an awful lot. And even learning a new skill is something that can be of great benefits. So
bit of neuroplasticity, eh?
Maybe by this time next year we will be elite cyclists. Who knows?
Maybe. I'm doubtful that I personally will be, but sure, I can keep pushing for that rainbow. Yeah, Jonny, thank you so much for joining us on the Living Well with MS podcast. We really, really appreciate it. It's been wonderful to hear your perspectives as a fellow Jonny, a fellow Northern Irishman, a fellow doctor, and a fellow person living with a chronic neurological condition. I wish you every success with all the brilliant initiatives that you have going on, and thank you again for your time today.
Yes, thanks very much. It's been absolutely fascinating. I've learned more about MS in the past week than I have in my whole medical career. So getting the message out. Keep getting the message out. Fantastic.
Thank you, Jonny.
Thanks Brilliant. A lot. Bye-bye.
Thank you for listening to this episode of Living Well with MS. Please check out this episode's show notes at overcomingms.org/podcast. You'll find useful links and bonus information there. Have questions or ideas to share? Email us at podcast@overcomingms.org, or you can reach out to Jeff on Twitter @JeffAlex. We'd love to hear from you. Thanks again for tuning in, and see you next time for tips on living a full and happy life with MS.